So I would do a vasopressor and then start to do the lesser invasive things. And then if those less invasive things, positioning, lessening the stimuli, turning the lights out, inviting the 500 family members to step out, raising the head of the bed, making sure we have midline, positioning, and then I would probably do mannitol or 3%, okay? Does that make sense? Mm-hmm. Okay. Because again, I can't just leave them with an ICP of 21, okay? I'm gonna try to do those least invasive things first, right? But I wanna make sure that I can't just leave them at 21, okay? Make sense? Yes? Okay. Do we feel like we have a good grasp on this, or would you like one more? Everybody's okay with math minus ICP? This will be your math, on part of your math on the exam, okay? I think I might have one more. Okay, just kidding, I don't. Okay, so let's talk about this patient. So we have a 32-year-old male admitted to the hospital after diving in the shallow end of the pool. Patient sustained a C4 spinal cord injury, okay? The patient has been in your ICU for 12 hours, okay? So whenever we add those things, right, we need to make sure we're looking at this. 12 hours, right? And then where did they sustain the spinal cord injury? Okay, so that's important, right? That should guide your priorities of care, okay? Which are what, okay? So what are your priorities of care? Anything that you're worried about. So take a second, or more than a second, a couple minutes, and tell me what you're worried about. What are your priorities of care? For the spinal cord injury, what are you worried about? That's great. You're listening. I'm so happy about that. So airway, right? This is the big one. When you have someone with spinal cord injury above C5, anything right higher than C5, you need to think C5 stay alive, right? You need to be thinking airway. And then in the patient presentation, I talked about the timing, right? Why do you think I included that? Why do you think it was important that I included 12 hours? I don't think we're quite there yet. Again, great futuristic thoughts, 100%. But think about when you have a spinal cord injury, any sort of injury, right? What happens at that site of injury? Swelling, exactly. So this patient has already been in there for 12 hours. We can think about, right, that swelling, that inflammation is getting worse, okay? So if they are not intubated, we are thinking maybe they should be intubated, right? Because we can think about that swelling with that timing is just getting worse and worse and worse, right? And their ability to protect their respiratory drive is going to be hindered, okay? So we also talked about, yes, I love it, lay them flat and mobilize, okay? When we get to trauma, we'll talk about that a lot, but C-spine precautions and backward immobilization when you have a spinal cord injury is so important. Why? We can't prevent that initial injury from happening. It already happened. He chose to dove in the pool and he went into the shallow end and hurt himself, right? But we can definitely prevent more injuries. How we do that is by immobilizing them, okay? Putting an Aspen collar or a C collar on them and then putting them on that backboard, okay? And making sure that we're not twisting, moving them in weird, crazy positions, okay? I like it. Those are great. Good priorities of care. Okay. So with this, right, patient becomes a little bit more lethargic and less alert. Physician orders an arterial blood gas. Okay, so this is what we're looking at. So this is like hard evidence. Timing is happening. We haven't done anything, and now look at where we're at, right? pH 7.10. What are we looking at? Is that high, low, or normal? Okay, it's low, right? pH 7.35, 7.45 is normal, so this is low. So we could say it's what? Acidotic or alkalotic?
Acidosis.
Okay, perfect. Respiratory acidosis. Alex, how did you come up with that?
High CO2,
Okay,
low pH.
okay, perfect.
Bicarb is normal range.
Okay,
The PaO2 I'd like to be above 80.
okay, so low.
Yeah.
Perfect, okay, great. And then as evidenced by our SAT, we know that they're low, right?
Mhm.
So not only do we have respiratory acidosis, right, but they're also hypoxic as well, okay? So if you had to guess, right, if you had to guess, how often do you think this patient's breathing? Just throw out a guess. Low, right? What do you think? Less than 10? Maybe 5? Right? So again, make it make sense, right? The patient has a C4 spinal cord injury. His respiratory drive is becoming hindered, right? So maybe he's breathing 4 times a minute, okay? And I can imagine, and you can also imagine, that those breaths are probably not quality, right? Quality intake, good tidal volume, right? The tidal volume is going to be a lot less because he's losing the ability to breathe, essentially, okay? And then this ABG is indicative of it, okay? Does that make sense? Okay. So we're gonna intubate him, right? We're gonna intubate him, and then we need to be worried about these 2 things, right? So what is the difference between spinal shock and neurogenic shock? Go look at that. We're gonna review a little bit. Got your test later today. It's great that we can insert this in there, okay? So what is the difference between spinal shock and neurogenic shock? And then who is at risk? Who is at risk for neurogenic shock? Are all spinal cord injury people gonna have neurogenic shock?
Quite possible.
Okay, so take a moment and let's do it. Let's talk about it.
Bobby, check.
Don't get these confused, guys. Okay, it's important to understand the difference. I love this. It looks like this is copy and pasted. Or someone's a very fast typer. I love it. Okay. So, spinal shock, right? Spinal shock is where the patient has flaccid paralysis, right? And loss of sensation, below the level of the lesion, right? So essentially, they can't feel anything, and then they're also paralyzed below the level of the lesion, below the level of the injury, okay? You could have them, they could have hypothermia and loss of bladder and rectal control, okay? Those kind of go hand in hand. So, neurogenic shock, right? Who are the people that have neurogenic shock? It says it right here. Those are the people that have the spinal cord injuries higher up. So cervical and thoracic. So how about our guy, the C4 guy that goes in the pool? Is he gonna have possibly both shocks?
Yeah.
Absolutely, okay? So we could think about like what a terrible ABG he had, right? And then what do you think maybe his vital signs were? In addition to his terrible ABG. He's really like in a world of hurt. So how are his vital signs, the C4 guy? If he's in neurogenic shock. Bradycardic, okay, you're making me guys a little bit nervous because I was like, oh my god, I'm taking the test today. Please don't look at me blankly, okay? So, neurogenic shock, right? So I heard bradycardia, what else? What else? Hypotension, okay, so their pressures are gonna be low, MAP's gonna be low, okay? And then, what's the third thing? Okay, warm and flushed, excellent. So temperature dysregulation, okay? And he could also have spinal shock, so he could have a twofer, right? So, going back to this really quick. So, with this ABG, right? So we have identified that he's probably going to be in neurogenic shock. He's gonna have spinal shock as well, okay? Our priority at this point is what? What's our priority? Airway, I hear airway, excellent, okay. So you get this ABG, the doctor's down the hall doing something else, you call him and you say, hey, yo, this is the ABG. He's like, okay, I'll be there in a minute, okay. So while you're waiting for the physician to come back, right, what are you doing? Okay, you can bag him, sure, absolutely. If he's breathing 2 times a minute, I love it, let's bag him. Irregardless, we can identify the fact that he's hypoxic, right? So the very first thing, you have to grab a bag valve mask, but what could we put on him? Very first thing. Like a non-rebreather, right? Did I hear that? Or did I just give you a non-rebreather, okay? But I could also bag him, 100%. Because again, I can't just leave him with a SAT of 89 and be like, oh, the doctor's gonna be here in a minute and just stare at him, right? Because we know that airway is a problem, right? So I'm anticipating that he's gonna be intubated, right? I look up and his blood pressure is MAP's in the 50s because he's in neurogenic shock, and his heart rate's in the 40s. So what other drugs can I anticipate having yelling at someone because I don't want to leave my patient, right? And again, nursing is a team sport, so I can say, hey, Bailey, can you go grab this for me? Atropine, excellent, perfect, because I don't love the heart rate in the 40s, right? And then what other drug might I want to hang? A vasopressor of some sort. Give me some. Norepinephrine, excellent. What's another one? Vasopressin, sure. In this particular instance, probably not the one to choose. What's another one that you can choose? Phenylephrine, exactly. Okay, and then the big daddy. What's the big daddy? Epinephrine, exactly. Okay, so hopefully I can just do some Levothed. I know I need to intubate him. Okay, but in the meantime, I need to hyperoxygenate him. Right? I need to do something about that sac. Okay, spinal shock. We can't really do anything about that. Okay, we can't really optimize that. We just are understanding that that could be the case. If there's a loss of bladder and rectal control, what am I worried about? What interventions could I do to help with that? What? Okay, a Foley, sure. And then loss of rectal control, it depends, right? I mean, if just making sure they're pooping, that could be the main thing with this, is making sure they're pooping, making sure they, we put that Foley in. Obviously, they can't live their life with a Foley catheter. They probably eventually will buy themselves a suprapubic catheter, okay? If they indeed have this, but hopefully, again, this spinal shock is only gonna last 1 to 3 weeks, okay? Questions about this? Okay. You may see a similar situation on your exam that we just talked about with neurogenic shock. Okay, so let's talk about this. You absolutely need to know this for your exam, okay? So this autonomic dysreflexia. This is something that happens when someone has a long-term spinal cord injury, okay? So a long-term spinal cord injury. So essentially what happens, right, well, we're gonna go through this little situation here. So what happens, again, long-term spinal cord injury. So something happens where there's a trigger, okay? In this particular diagram, they're talking about that the bladder, right? There is a blockage in the catheter and the bladder is filling up with too much urine, okay? Anybody been on a road trip and you have to go pee, but whoever's driving is like, no, we have an hour left. You gotta hold it, right? And you're like, oh my gosh. You start to sweat, right? Your stomach starts to hurt a lot, okay? So you know you have to go pee, right? You have all of that stimulus happening where you're like, I am gonna pee my pants right now. And then when you stop, you get out and you're like going like this because you can't make it to the bathroom because it hurts so much, right? We've all been there, okay? We've all been there. I am one where I'm like, just pull over, I'll be on the side of the road, okay? I'll be on the side of the road. We'll open up the doors so hopefully people can't see me, whatever if they can, okay? So, again, we have some sort of trigger, okay? In spinal cord injury patients, right, the trigger could be bladder distension. It could be that they are constipated, right? That they have stool impaction. It could be that their clothing is too tight, okay? Could be that they're laying on a pen cap or a Kuros cap. Happens all the time, right? Find stuff all in the bed. Okay, so something has caused this sort of trigger, okay? So the stretched bladder sends nervous impulses to the spinal cord, just like I talked about, right? Normal, you all don't have a spinal cord injury, so you understand that those kinds of stimuluses happen, right? When the impulse reaches the level of T6, the sympathetic neurons here become activated. So they release those chemicals, norepinephrine, right? It's the stimulus. It's the stimulus to say, hey, something is wrong. We need to do something about it, right? So then what happens, right, is that norepinephrine, it's like a natural norepinephrine in your blood, okay? It's part of your fight or flight, right? And so these chemicals, they cause the blood vessels in the skin of the abdomen to constrict, right? Your blood pressure rises. Just like in your road trip, your blood pressure, you gotta go pee, I'm sure it would be super high, right? That's how you think about this. So then what happens, right, is that your blood pressure's rising, your bladder is distended, we gotta do something about it, we don't want it to burst, right? So then this rise in the blood pressure is detected, right? Your heart and your brain are like, oh, something's wrong. Something's wrong and I need to do something about it, right? What's going on with all this blood pressure? Why is this blood pressure elevated, right? And so then the brain has two ways it can oppose the rise in the blood pressure, right? Because the brain's like, I can't have that. This is screwing up my homeostasis. I don't like that, okay? So it first sends the message via the parasympathetic vagus nerve for the heart to slow down. It's letting it know, hey, I need you to slow down. I don't want all this blood pressure. It's too high. You need to slow down, okay? But unfortunately, the other message that's supposed to go down the spinal cord, right? This is the big thing. This is like the finale, right? It doesn't get to it, right? The message that's supposed to go down the spinal cord to alleviate this, to let you know that something's wrong, doesn't happen, okay? So the injury to the cord stops those messages and only the blood vessels above the injury dilate, okay? So essentially, this is why autonomic dysreflexia only happens with spinal cord injury patients, okay? The message, because this is where the injury is, the message does not go down, okay? It does not go down. It stops. There's a big roadblock. You guys know the storm that happened? What day was that? Friday? Okay, it's washed out. There's no road anymore, okay? So there's no road here. It stopped. So it becomes hindered, and now we have this issue where the patient's blood pressure is sky high, they're bradycardic, right? And they're just trying to tell you, hey, something's wrong with my bladder. something's going on. The catheter's blocked, my bladder's distended, okay? So this is where it comes into with you guys as nurses. When you are caring for someone that has a spinal cord injury, you need to be on the lookout for autonomic dysreflexia, okay? So this is another picture. That's kind of the pathophys as to what happens. This is another picture.
So is the main symptom then just gonna be the high blood pressure?
It can be, it's, and all this other stuff. How do I make this bigger again? What do you do? Anybody remember? Who's my techie people?
Make what bigger?
You know this. Can you see this?
No.
I know.
Hit Control plus.
Control plus. Not this? Nope, plus. There you go. See, Alex, you knew. You're the techie person here. Okay, so here is another pictorial depiction, right? So here are all the stimuli, okay? So usually it's people that have T6 injuries or below, okay? So restrictive clothing. Someone put their belt on way too tight, okay? They have too tight socks. I've seen that, right? Pressure injuries. They're laying on a Kuros cap. That has happened at the bedside, right? And so they have a full bladder because there's sediment in their catheter that has blocked it. They have fecal impaction, right? Because again, remember, these patients, they're at risk for a lot of things because they're not getting up and moving around, right? They're paralyzed from wherever the injury is below, okay? So to speak to your question, this is the symptoms, right? So above the level of injury, so let's say the injury is T6, that's where the road is washed out, okay? That's where the signal has stopped. So above it, you're going to look flushed, okay? The patient is going to look like they're flushed, they're sweaty. They're going to say that they have the worst headache of their life, okay? You're gonna look up at the monitor and see that they have high blood pressure in the 200s, okay?
Ooh.
In the 200s, high blood pressure, weirdly, they're gonna be bradycardic, okay? They're gonna be bradycardic. I said that they're sweating, right? And then below the injury, right, so their legs, they're going to be pale, cool, and they're not gonna be sweating. It's gonna be this weird, like, Harlequin situation, where above the injury, they're gonna be hot, sweaty, blood pressure's gonna be high, bad headache, okay? And then below, the extremities are gonna look pale, cool, and then no sweating, okay? Does that make sense? So this is how your patient's going to present. How you treat this is you have to figure out what the stimuli is and fix it. So is it that they have a full bladder? You drain it. You either put a new catheter in, you do a straight cath, thank you.
Well, the other day we received another nurse that was next to us received a new patient for the ICU, and they were like, "Why do we have to scan her every 2 hours and straight catheter every 2 hours if we need it?" But she had a spinal injury. I think
Yes,
that was
yes.
to avoid this kind of.
Yes, absolutely. Oftentimes, the people that have spinal cord injuries, they get admitted. They come to the ICU for autonomic dysreflexia, okay? So you have to figure out what the trigger is and then accordingly deal with it, okay? So fecal impaction, make them poop, right? Take off their clothes, figure out what pressure injuries, right, is causing that, okay? And again, guys, remember, yes, I know that we love pharmacology. I love pharmacology, don't get me wrong. And yes, you could give an antihypertensive to this patient to help bring that blood pressure down, but that is not going to solve the issue, okay? Let me say that again. That is not going to solve the issue. The issue is you need to figure out what the trigger is and deal with it, okay? You can give an antihypertensive, but again, that is not gonna be sustained answer, okay? Does that make sense? Okay.
Just curious, I know you said spinal injuries. Someone with like spina bifida, could that be a thing that happens to them too?
I don't know. That's a good question. I'm not sure, to be honest. I feel like with spina bifida, the connection though isn't totally severed, is it?
Not necessarily.
It depends. I think it depends.
I think it depends, right?
Like I have a I work at a preschool and I have a little girl who's got spina bifida. I don't think she can feel anything from like knees down,
Sure, sure.
but she also doesn't have control of her like
Her bowels.
bowels or bladder.
Sure, sure, sure.
So I don't.
I mean,
But
it
I'm
certainly
curious
would be
if something like
something,
that
yeah,
would
I'm not
happen.
sure. I would have to ask someone to see. I've personally never had a patient with that. But I would say that if, you know, pathophys-wise, if the
It's
connection
whatever
is
signal is
severed,
blocked.
yeah, if the connection is severed, they could be at risk for this 100%.
My wife's ex-husband had spina bifida, and
He had that?
I don't think he had autonomic dysreflexia, but he had spina bifida, and he just had reduced sensation in his legs.
So I think that, again, depending on the severity of it, you could be at risk if the connection is severed. Okay. Okay, questions about this? Okay, you will see questions. Okay, here. Now minus. See? I got it. Okay, let's do this question.
It's me.
Okay, you're providing an in-service to a group of new graduate nurses. Wow. It's not even that long into the lecture. I'm already tired of having trouble reading. On the cause of autonomic dysreflexia. Select all the most common causes you can discuss during the in-service. Okay, so is hypoglycemia a cause? Negative Ghostwriter. It is absolutely not a cause. Is a distended bladder? Yes, 100%. Is a sacral pressure injury? Yes. Is a fecal impaction? Yes. And then kinked Foley catheter? 100%. Yes, absolutely. Be careful of this question, right? It is specifically asking about an autonomic dysreflexia, okay? It's specifically asking about autonomic dysreflexia.
My internet usually is fine.